And then today, our second lecture, it's going to be about lung transplantation. This lecture is going to be presented by Dr. Islam Mohammed. He's an assistant lecturer, Anaesthesia Department at Ain Shams University Hospital, Egypt. He has also done a visiting scholarship in Anaesthesia of heart and lung transplant, Ohio State University. I'll leave the talk to you, Dr. Islam. Are you still here?
Thank you, Dr. Monique, for this fruitful lecture. It's my honor to be here among the scientific committee of the MEGA online course. This is my great university in Egypt, Ain Shams University. I have no conflict of interest, so I can start right now. Our dear audience, it's about 45 minutes, so please hold your seatbelt and bring your coffee. Yeah, it's working. This is a nice framework. I wasn't interested in the cardiac anesthesia or even lung transplant. This is a nice framework how to make a change in your career or generally in your life. To make a change, you should have a vision, skills, incentives, resources, and action plan. If you have no vision, you get confused. If you have no skills, you get anxious. If there is no incentives, you will suffer from resistance. As in some developing countries, if there are no resources, you will get frustrated. Finally, if you plan, there's gonna be a false start. About lung transplant, this is the story of the lung transplant, which started in the middle of the last century. At 1990, they started the living loper. This is a very important date for us in Egypt because I hope we will start our program for lung transplant at 2021 by donation of the living loper. One of the most important or two most important steps in the story of the lung transplant is the ex vivo lung perfusion and the donation after cardiac death. These two steps cause expansion of the donor lung, so more and more lungs are available. Ex vivo lung perfusion is invented by Dr. Steen. He invented this enhancing and assessment of the marginal lung. I mean marginal lung, which is not the young healthy. So you can transplant a smoker lung after enhancing it. And the donation of cardiac death for sure expand the pool of donor lung. So after becoming the single lung transplantation is the dominant, we can transplant double lung. And this is the trend right now, double lung transplant. When you pick a lung, you have about 6 hours to avoid the ischemia-induced dysfunction. So they use the helicopter to transport this organ. And at the hospital, if the lung is marginal or borderline, they get it into the lab to start the ex vivo lung perfusion. So what's the ex vivo lung perfusion? It's about the game changer of lung transplant because as we said, you can transplant a smoker lung. So more and more lungs became available. This is here. This is the lung in this dome. You ventilate it with a lung protective strategy, and you can perfuse it with what's called Steen fluid. Steen fluid is the fluid invented by doctors at 2000. It's like the prepared cardioplegia for enhancing and decrease the interstitial edema of the lung, so it can improve it. This is the content of the Steen fluid, and this is a very nice video from the ex vivo lab. As we can see, this is the ventilator. This is the lung inside the dome. For sure, it's the easiest way for intubation. As we can see, this is the canally in the pulmonary vein and the pulmonary artery, as we see here. And this is a leukocyte filter to decrease the burden or the load of the leukocyte. So they ventilate the lung with lung protective strategy, push the steam fluid, some methyl prednisolone, subheparin to decrease the to the interstitial edema, so they more or less can improve this lung. And after 4 to 5 hours, they get the decision or can make the decision if this lung is good for transplantation or more. So this is a very important stage or a very important step in the story of the lung transplant. Surgery. This is Dr. Brian Wesson, one of the most outstanding surgeons in Ohio State University. I can't remember this Saturday when we started the list with robotic cabbage. Then after doing heart transplant, and at the midnight there was a single lung transplant. Single and double lung transplant. Single lung transplant, the incision is simple thoracotomy. It's as we said, after availability of the lung, it's only about 25 of cases. We use what's called one lung ventilation, and ECMO is not our daily routine. The bilateral or double lung transplant, the incision is either sternotomy or this clamshell, like you opening your car hood. It's most of cases, and we use sequential one lung ventilation. This is an important consideration we will discuss later. In these cases, mostly we use cardiopulmonary bypass or the VA, venous arterial ECMO. This is the protocol from Ohio State at 2013 and updated till 2019. You will find every single data you need in this page. If you are searching about the inclusion and exclusion criteria, you can read it from this slide, but I go into the preparation of the room. This is the OR at Ohio State. We can see the infusion or the infusion reps. This is the anesthesia machine, monitors. This is for electronic documentation, and this is our important TE and bronchoscopy. Monitoring, we use the standard monitoring. We put 2 A lines, radial and femoral. This is very important, and we use it even in Egypt in the liver transplant, because after reperfusion, radial artery get dampened. So you will push more and more vasopressors or inotropes. The femoral artery can give you a true or accurate insight about the hemodynamics. So in a very nice comparative study, it decreased the need for vasopressors and inotropes. Pulmonary artery catheter, some will go for to say it's invasive. No, it's mandatory in lung transplant, because not only for sampling, it gives you like continuous monitoring of the, as you can see here, the cardiac output and the cardiac index. Cerebral oximetry and the thromboelastography. This is cerebral oximetry. It's very important to direct even the red blood cells transfusion. The role of TE, transesophageal echo, is very important in lung transplant to assess the RV. All through the operation of the lung transplant, you should watch the RV. Also, it's important for assessment of the volumetric, you know, as in whole thoracic surgery. We tend to, I will not say hypovolemic, but to avolemic or a little bit hypovolemic to avoid the pulmonary edema or excess lung water. You can check the anastomosis of the pulmonary artery, pulmonary vein by the duplex, and you can detect any complication like the air embolism, especially after connection of the pulmonary vein. Some air in the LA and the LB, and this is for sure can cause many complications up to coronary ischemia. This is a nice quote about the pulmonary venous flow, Doppler. Yeah, what we knew. After all this monitoring, I'd like to emphasize on this near future. This technology brought by Edward. It's introduced in Ohio State University just this year. It's called HPI, or Hypotension Prediction Index. Hypotension Prediction Index can tell you about the upcoming incidence of hypotension episodes 15 minutes, 10 minutes, and 5 minutes before the incident. So here it's about 88/100. So after 5 minutes, it tells you that there is episode or there will be an episode of hypotension. Not only, this is what's called a secondary screen. This marvelous or awesome device tells you about every step about the hemodynamics, cardiac output, systemic vascular resistance. So it tells you what you should give, fluids, vessel pressures, or any throw. So it carry the anesthetist from the phase of reactive. We react to the hypotension to the proactive stage. We can predict the hypotension and we can manage before this incident. So it's more or less a fresh technology. This is the drips. As we can see, everything is controlled through controlled infusion, and it comes in a pre-made way. That is the antibiotic protocol. This is for sure, Milrinone should be ready for the sake of the RV. As we said, you should watch the RV. If you watch your RV, you will save your back for sure. This is another drips. Yeah. This is a very important. The inhaler epoprostenol. It's a prostaglandin for the pulmonary. Works as a pulmonary vasodilator. As we can see here, this is the pre-meat syringe containing about 1 milligram epoprostenol, and we put it in this inhaler connected to the inspiratory limb. This is a routine daily, this is a daily routine in the lung transplant that we put the inhaler epoprostenol. Induction of anaesthesia. Induction is a very crucial part of this surgery. So please make your surgeon and perfusionist ready in the room. Why it's a crucial part? Because all what we give will decrease the cardiac output and to some extent will increase the pulmonary vascular resistance. As we can see, suppression of sympathetic system, vasodilation, and all these postulated mechanisms will decrease the cardiac output. Number two, increasing the pulmonary vascular resistance, which will affect the RV again. If there was like light anesthesia, all of this hypoxic, hypercarbic, and acidosis will increase the pulmonary vascular resistance and cause RV dysfunction. Induction agent during sedation, please make sure that your patient is not hypoventilated. They don't use etomidate, they use propofol as usual. About the cranium, you make sure that you give more and more dose, about 1.5 milligram per kg, to avoid the aspiration, because as we said, it's about timing. When you pick an organ, it's about 26 hours. You will call the recipient. If he is not fasting, you will not postpone the surgery. So there is a risk of aspiration for sure. The purely about the volatile anesthetics, that please don't go beyond 1 mg of any volatile anesthetics, because it will attenuate what's called hypoxic pulmonary vasoconstriction. Hypoxic pulmonary vasoconstriction is the god physiology. What will save you during the surgery is the hypoxic pulmonary vasoconstriction. So please maintain it, and we will discuss about it after about 5 to 6 slides. Induction is crucial. So let's see this nice case report. It's a real case report from Ohio State. Happened, I think, 2014. Our patient is 48-year-old female patient, COPD and smoker. This is the pre-transplant workup. Sorry, I didn't mention the abbreviation, but this is the pulmonary function test. It's lung perfusion quantification, right, and hard catheterization. This is the EPG. All of this are accepted, except for sure he is a little bit hypoxic. The most important is the CT chest. This patient is COPD smoker, so there is a little bit emphysematous poly, as we can see here. Other investigations were normal. At the OR, after induction of anesthesia, I think this is a good chance to see what practically occurs at lung transplant. On Ohio State, we put endotracheal tube. Why endotracheal tube first for the double lumen tube? To make bronchoscopy. Why we make bronchoscopy first? It's like surgical preference to check the bronchial tree, do a little bit suction. Then after doing the bronchoscopy, and for sure for research, any research study, we replace it with double lumen tube over for sure exchange catheter. Means anesthesia started, then they put their vascular access. We said that you need center venous line and you need Swangans or pulmonary arterial catheter. This is Mac introducer is a very versatile device. It's called multi-lumen access catheter. You instead of doing two punctures, one for center venous line, one for the pulmonary arterial catheter, you will do only one puncture, and you can insert the pulmonary spine glands or pulmonary arterial catheter through this port. So you have two ports for the center venous line, and you have this pulmonary spine glands through the middle port. So it's only one puncture, one bullet, and you get all the targets. At the OR, after intubation, heart rate increased to about 140 and 150. For sure, most of us will say, yeah, the patient is a little bit conscious. I will increase the depth of anesthesia. But please respect the hemodynamics. Tachycardia may be more dangerous than the bradycardia. Bradycardia telling you the heart is slowing, but tachycardia may say may mean further complication. After tachycardia increased, I think increased the depth of anesthesia. They put the pulmonary arterial catheter, and after about, you can see here, about 30 minutes, the pulmonary arterial pressure increased. Then 10 minutes, the blood pressure decreased to 60/40. There is a frank shock. They push norepinephrine, epinephrine, vasopressin, the blood pressure improved, but still low. Thanks to Allah, they made a surgical skin incision. Just after opening the left chest, this patient was for left lung transplant. After opening the left chest, the blood pressure rebounded to 200 over 100 meter mercury. So I think this was too much info. So what happened? This is the electronic sheet. I think this is a very nice photo. You can see this is the A line. A line reach here is about 80. Yeah, you can see it's here right now. This is 100. So the A line is 80/50. Then after left chest open, it increased or rebounds to 200/100. So this is very important to us as anesthetists, that there is something you can fix, but another thing the surgeon should fix. So what happened? This is the list of the differential diagnosis, but I think 80 to 90% of us figured out that it was tension pneumothorax. Why tension pneumothorax? Because this is the explanted lung. As we can see here, this is an emphysematous poly, mini emphysematous poly, one of them ruptured. So there is tension pneumothorax. After opening the chest, you converted it from tension pneumothorax to open pneumothorax, and the pressure back to normal or a little bit hypertensive. This patient was saved, extubated after 1 day, and discharged to his home or to her home after 20 days. A good clinical tip here is about the transesophageal echo. No one knows about the pneumothorax because of no one knows about pneumothorax except after opening the chest and watching all this emphysematous poly. So, does echo help, or did echo help in single lung transplant in such a hemodynamic unstable or life-threatening situation? I doubt it. Why? Because it's a left-sided lung transplant, so it's left up, lateral position. So your heart is not that straight one; it's mal-rotated. Add the pneumothorax. This is a very nice photo. This is the mass effect of the pneumothorax. So you have a mal-rotated heart compressed with the pneumothorax. Please tell me about the image acquisition. I think it's very difficult. So the report of the TE showed that LV is poorly visualized, RV is also poorly visualized. So TE doesn't help or didn't help in this such. Yeah, this is a nice algorithm about the diagnosis of pneumothorax by ultrasound. We can read it later. The airway management. Every anesthetist expected that, but the reality is about that. It's our bad luck. This is a very nice quote. Said, "The hard work puts you where the good luck can find you." So It's a very important issue in the lung transplant is the airway management. We for sure talk about lung isolation. We use the fiber optic bronchoscopy or the bronch for confirmation of the position of either double lung tube, double lumen tube or bronchial blocker, a little bit section, and to check the bronchial anastomosis. I was very lucky to get this photo. This is, as we can see, this is the balloon of the double lumen tube, and this, I think it was double lumen or the east blocker, and this is the stitches at the bronchial. So you can check the anastomosis well. Lung isolation. Double lumen tube, I will not discuss it, but briefly, if you put a double lumen tube here and you and through the tracheal port, you push your or introduce your fiber optic. If you are at the carina, you will get this photo. A balloon here and the other bronchus is here. If you introduce it a little bit in the right bronchus, you will see the Mercedes-Benz sign. Why we use the left tube? For sure, to avoid the early takeoff of the right bronchus. You can imagine this pilot balloon will be inflated right here. So you will get a right upper loop collapse post-operative. If you put the bronchoscope in the bronchial port and you are here right now, you will see only two holes, upper and lower, because the left lung for sure is upper and consists of upper and lower loop. Yeah. I will talk about tube exchanger. It's very important. If you put double lumen tube, please, when you exchange it, when you exchange it with single lumen tube at the end of surgery, please use the tube exchanger. It's, you know, safety comes first. Yeah. One of the most recent devices used for lung isolation is the bronchial blocker. This is called ease blocker. As we can see, it's very easy. Just put the blocker at the carina level, then you inflate the right if you want to block the right lung, or inflate the left if you want to block the left lung. So it's called ease blocker. Now, what's our protocol in our on Ohio State University? We put into tracheal tube, no more double lumen tube. We put into tracheal tube, but with a wider diameter, maybe 8 to 9. There is a room for both the fiber optic and the double lumen. So we need for the fiber optic and the bronchial blocker. So we need a wide for endotracheal tube. And this is the protocol which is settled right now. Which is better, double lumen or bronchial blocker? Bronchial blocker may take a longer duration. For sure, there is no longer duration with the ACE blocker, but this randomized control study said that bronchial blocker has less post-operative hoarseness of voice, and this is a good issue to consider for sure. This is a very nice book. I read it on Amazon about the management, how we can win forever. The intraoperative management, we will talk about the ventilation strategy, hypoxia, the hemodynamic support, breathing, and reperfusion. About the ventilation strategy, I said we use what's called one lung ventilation, either in single lung transplant or sequential lung ventilation in the double lung transplant. In the single lung transplant, the physiology is very awesome. Why? Because it's a lateral decubitus. So the dependent lung is done, it's not the operative lung. The dependent lung, by gravity, it's well perfused. By your ventilatory management, it's well ventilated. The best matching. The upper or the non-dependent lung, it's the operative lung. The surgical manipulation will decrease the blood flow. The gravity will decrease the blood flow. It's not ventilated. So more or less, less perfused, less ventilated. This is a good matching. Who will save you is the hypoxic pulmonary vasoconstriction. When there is a little bit hypoxia, the blood is diverted away from the non-ventilated areas. So this will improve the matching. But this is not good all through. Why? Because as the double lung transplant, you know, you ventilate here, the surgeon will transplant here. Then the surgeon will go here to transplant and you will ventilate the new lung. The problem here is the hypoxic pulmonary vasoconstriction has two stages. acute stage and delayed stage. Delayed stage up to hours. So let's imagine this lung is the new lung. There was hypoxic pulmonary vasoconstriction, which is still ongoing. You will ventilate now this lung. This lung is less perfused. You ventilate better a less perfused lung. This is called VQ mismatching. So you should predict a little bit hypoxia because of the delayed hypoxic pulmonary vasoconstriction in case of sequential one lung ventilation at the double lung transplant. How they avoid all of this? By cardiopulmonary bypass or VA ECMO, so no more either hypoxia or nothing else. Which pressure control or volume control, there is it's not big deal. There is no big difference between both of them. Please keep the list FI2 to mean saturation more than 90%, PEEP5 and more. Tidal volume 4 to 6 ml per kg. This is like the lung protective strategy. IE ratio from 1 to 2 to make a room for the air to get out. You know, we should avoid dynamic hyperinflation. And the respiratory rate, you should follow the hypercapnia to avoid increased pulmonary vascular resistance, which will affect the RV and cause RV dysfunction. This is about ventilation before the transplant. If you got hypoxia, what you will do? You have now ventilated lung and non-ventilated lung. If you have, as regards the ventilated lung, please do bronch. Maybe there is a little bit secretions, a little bit blood. You can get it out. So the hypoxia will be improved. Increase the FI2, increase PEEP, do some recruitment. A non-ventilated lung, but I think it's technically difficult. We can use this. You know, this bag. I hope it's clear. It's we connected it as we can see in this photo. This is the ventilated lung. This is a non-ventilated lung. I will put it here. It's pressure from 1 to 10, not more. You can make like pressure support ventilation for the non-ventilated lung, but it's for sure technically difficult in single lung transplant. And you can make some recruitment for this non-ventilated lung. After increasing FI2, increasing PEEP, do bronch, there is still hypoxia. What the other solution? First, you can get ICU ventilators. There is a live food from Ohio State. This patient suffered from hypoxia. So we get the ICU ventilator because it can offer you more and more modes, which may improve the hypoxia. Still hypoxic, go for VV ECMO. Still hypoxic, you can ask the surgeon for of the pulmonary for the transplanted for the native lung, which the surgeon is going to transplant it. The same physiology, decrease perfusion, decrease ventilation, you will improve the matching between ventilation and perfusion. ECMO is not ECMO doesn't mean end of hypoxia. Is there hypoxia after VV ECMO? Yes. If there is hypoxia, please please check the cannula position by the TE. I think this photo is a nice one. We can just zoom in. Yes, this is the bicaval view. This is the cannula of the VV ECMO through the SVC. So you can see its position clearly. If the position is good, ask the professional to check the ECMO. ECMO is like ventilation. It's like the ventilator. You can ask him to increase the FiO2. The most important slide is about the hemodynamic support. Always watch the RV. How you diagnose the RV dysfunction? By using the transesophageal echo. You can see if it's dilated. You know, this is the normal between the LV and the RV. If it's hypokinetic, you can go for the Swan-Ganz to tell you about the pulmonary artery pressure, the intravenous pressure. All of this will tell you about the RV dysfunction. How could you manage the RV dysfunction? By decrease the preload, decrease the afterload, enhance the contractility. Suicide RV is a very nice term. That the RV there is some sort of increasing afterload, and then you push fluid, so the RV will be stuck between increased preload and increased afterload. So please decrease this fluid decrease the afterload by ibuprostenol inhaler. We talk about it, or inhalation of nitric oxide. Of if ibuprostenol is not available, you can enhance the contractility by milrinone, epinephrine, pharmacology, or VA ECMO. So VA ECMO or cardiopulmonary bypass for lung transplant, which is better. They in this nice study at Toronto, they found that ECMO is associated with less blood transfusion, less ICU length of stay, less time or on ventilator days. So it looks better than bypass. ECMO doesn't mean no problem. This is a very nice photo from Ohio State for this case. You know, he is the same case who suffers from hypoxia. If you remember, this is the ICU ventilator. I just want to, yeah. I hope it's clear. This is, you can see this is facial cyanosis. The face of the patient get blue after cannulation of the ECMO. You should inform the surgeon to check the cannula. This is called SKT syndrome or superior vena cava syndrome because of the malposition of the cannula, which is in the SVC, as we can see here in the VV ECMO. This is a cannula from here, and this cannula go to SVC. So if this cannula is malpositioned, it will obstruct the flow from the face and it cause facial congestion. This is the photo again. Bleeding. Bleeding is not a big issue at lung transplant, but to manage it, you should consider the thromboelastography. It can tell you what your patient need, cryo, precipitate, fresh frozen plasma, or any one of the coagulation factor. You should use cell saver to save the blood. And this is a very nice device called the rapid infuser. Rapid infuser collects the blood from cell saver, from the crystalloids you give to your patient, from the blood products, and they push it into the patient's circulation with a very nice rate, 500 up to 750 ml per minute. You can push half liter of blood fluid to the patient in only 1 minute. But for sure, in thoracic surgery, we are not using this rapid infuser. The reperfusion, as we can see, when the blood came back or comes back to the lung, is a very critical time. Before the clamping of the pulmonary artery, we give heparin. After the clamping, we give methylprednisolone. This reperfusion, the same as ischemia causing lung injury and the multi or multi-organ dysfunction. This is the postulated mechanism of the ischemic reperfusion injury. What the rule of anesthetist at reperfusion? You should do 3 steps. First, go for the TE to check the VA ring or more air embolism, because the air embolism can cause coronary ischemia. You will find your RV not functioning well because of a little bit air embolus here or there. If the RV is hypokinesia from the coronary ischemia, and you can check the anastomosis of the pulmonary vein or the pulmonary artery. Do prong for suction, for check anastomosis as we said. And now, what about the ventilation of the transplanted lung, the new lung? You should use low FI2, make some recruitment, and they talk about the differential ventilation, especially in single lung transplant. Why? Now you have a native lung, which is not good, and in transplanted lung, which should be very good. You can't, one size doesn't fit all. You can't push the ventilator set for both lung was the same. So you can make what's called differential ventilation between the transplant lung, which assumed it to be good, and the native lung, which is for sure not good. Ventilation of the new lung, in this study, they used pressure control more than volume control. They used tidal volume of 6 ml per kg for sure of the recipient, not for the donor. So the new transplant, the transplanted lung, you will ventilate it with tidal volume of 6 ml per kg of the recipient, not the donor, predicted body weight, limiting the FI2, P5 and up, and maintain the plateau pressure not more than 30 as the lung protective structure. Excavation, single lung transplant. I think right now, this study was very old, about 2003, and they talk about early excavation after single lung transplant. Early excavation means excavation inside the OR till about 3 to 6 hours after the operation. I think it's improved at 2020, and this reflects the improvement of the learning curve. So a single lung transplant could be excavated inside the OR. My own experience, it's only one case. Transportation is a very critical time, and this is very important about the double human tube. I was lucky to attend a very dramatic case. At the end of an operation, it was robotic cabbage or minimal invasive mitral or something like that. But the idea is that we put double human tube. Now we will transport the patient. The protocol say that please change or replace the double lumen tube with a single lumen tube through a tube exchange catheter. The consultant said it's easy incubation. I will make the resident to put the tube without the tube exchange catheter. He put it esophageal and the patient developed a cardiac arrest. A hypoxic cardiac, it's not cardiac arrest, but develop hypoxia up to slowing of the heart rate. So please, there is no flexing here. Double human tube, replace it with tube exchange catheter. It was at the end of the surgery. Surgeon is happy, anesthetist is happy, everyone is happy, and this traumatic end was very awful for sure. During transportation, you should be fully equipped, and the reversal of muscle relaxant agent is of utmost importance. I faced a patient. It was like was a surgery of replaced aorta. They replaced the aorta from the arch of aorta till the iliac bifurcation. They didn't reverse muscle relaxant, and the patient suffered from delayed recovery at the OR, and everyone thinks that, there is a spinal cord ischemia. But after reversal of muscle relaxant, the patient get conscious, and everyone was happy. Finally, the research agenda. What are the field of study in the lung transplant? For sure, the ex vivo lung perfusion, because as we said, it expands the pool of the lung, so more and more lung available. So you can do the double lung transplant, because simply you, as the single lung transplant, you put one lung. The other lung will cause what's called acute hyperinflated native lung. It's hyperinflated, mostly emphysematous, and it will compress this new young small lung. Bioengineered lungs, I think nowadays there is bioengineered kidney, so we are hoping, or we are looking forward to bioengineered lung, and for sure it's all about the genetics. Our home message is that please, the COVID pandemic, protect yourself and stay safe. Finally, this is the last slide. This is a very nice about astrology in ancient Egypt. Here you can see Nefertiti, one of our most beautiful queens, give her husband a plant. They said it's about opium to cure him from an emergency pain. I hope Dr. Dominique is still here and said that. Thank you, our audience, and I apologize for this long lecture. Thank you.
Thank you, Dr. Islam. Can you hear me?
Yeah, well.
Thank you, Dr. Islam, for the excellent presentation and thorough presentation. So I've got two questions for you. So one question is asking about is there any role for pulmonary artery catheter in the presence of transesophageal echo?
Yeah, for sure. Yeah. When you are expert in transesophageal echo, you will know that to detect a cardiac output, you should have two readings. You can imagine now the patient, the blood pressure is low, and you should go for the aorta, then go for the R2, for the L2O2 to detect the cardiac output. So Swan-Ganz give you a continuous monitoring of the cardiac output, not only cardiac output, systemic vascular cells, the cardiac index. So please stop saying it's invasive. It's a very, during the multi-axis human catheter, it's very easy. For sure, there is some complications. I can't forget the day when the surgeon stitched the balloon of the pulmonary swine glands. It's for sure, complications happen. But for sure, continuous monitoring is very, very important. You can see in the case report that the patient is about to be crashed after induction of anesthesia. So it's very important because it's continuous. If the TE will give me continuous monitoring of the cardiac output cardiac index, I will say chapeau for the TE.
I've got another question. Would you please mention the post-operative pain management?
Yeah, it's my question for the audience about the peripheral nerve block for the clamshell incision. I searched for it many times, and some talk about quadriceps lumborum, it's not effect. Some talk about many things, but it's very difficult because it's a transverse incision. Epidural carry for sure the risk of neuroaxial hematoma, especially with all this heparin we get. So in Ohio State University, the protocol was only intravenous opioids, especially codeine.
Okay, I got another
because
question.
The post-operative, my answer is the protocol was intravenous opioids.
So intravenous only, you don't do a paravertebral block or anything?
By
the surgeons.
I asked about that, but they said it's a preference to avoid any neuroaxial blocking or neuroaxial analgesia in this case.
Okay, and another question: how can anesthetic? What is your anesthetic maintenance during transplant?
In the case report, it was sevoflurane. They use sevoflurane as usual. Some talks about, yes, this is a very good question. Some talks about TIVA, total intravenous anesthesia, to avoid, they talk about TIVA only to avoid increasing the MAC of volatile anesthesia to maintain the hypoxic pulmonary vasoconstriction. I said that if you go beyond 1 MAC, you will attenuate the hypoxic pulmonary vasoconstriction due to the vasodilator effect of volatile anesthetic. But till now, as general and spinal, TIVA, there is no privilege for TIVA over the volatile anesthetics. So they use volatile anesthetics, and more or less there is propofol infusion to decrease the concentration of the volatile anesthetic. So the maintenance, volatile plus or minus propofol infusion.
And another question: how much time?
I'm happy with all this question, for sure.
Yeah, how much time is required to take over the spontaneous ventilation of newly transplanted lungs?
Yeah, he mean that or what?
I think how much time required to leave the patient to spontaneously ventilate in the newly transplanted lung?
No, it's not. There is no ventilation. I think he means that.
I think post-operative. I think, I'm not sure.
No, I can't understand.
Oh, I think he mean when can you extubate your patient?
Yeah, we talk about if it's double lung transplant, it's a different story for sure. During my business scholarship at Ohio State University, there was a research about the microbes at the newly transplanted lung, so they maintain the patient ventilated till the next day to take a specimen or sample from the OR, then 24 hours. But single lung transplant, which wasn't in this research study, like any open heart surgery during the first 6 hours. Because I said that I attended one case admitted in the OR. So 6 hours.
Another question asking about the immunosuppression plan used after lung transplant.
Yeah, in the protocol, for the sake of time, because Dr. Saad was insisting that I will not
take your time.
For 2 minutes. Yeah. They give methylprednisolone only after declamping, as I said, about 500 milligram to be 5 to 6 milligram per kg. The another immunosuppressive, the protocol in Ohio, that they will not occupy the anesthetist with all these drugs. The immunosuppressive has been given to the patient before entry to the OR. So you will only give heparin before declamp and the methylprednisolone after declamp.
Dr. Islam, do you give any thiopentone on bypass? Thiopentone.
The perfusionist is responsible about that, but no, I didn't see thiopental in either in bypass. I can't remember, but it is not in the protocol.
Islam, if you don't mind, I have questions. I am not expert as you in thoracic anesthesia, but you mentioned at the end of the operation, you changed the tube from double lumen tube through exchanger, and some events happens if the junior staff is dealing with this. Why not from the start we are using, for example, univent tube, and univent tube you can take it out the blocker and you can send as not double lumen, only one lumen tube.
We do what you mentioned. Now it's a single lumen tube, single lumen, but it's a little bit wider. I mean, 8 to 9 millimeter of the internal diameter to put the fiber optic to put the bronchial blocker. So we did what you mentioned, sir, right now. But I mentioned a case in it they need double lumen tube. But the protocol now, especially after is blocker, is blocker is very easy. Just hook it.
I know.
Then, thank you.
I mean, univent tube, it contains itself simultaneous with the blocker. Univent, not the usual tube, and you insert the is blocker. The univent tube, it contains already the blocker. You can take it out and you can use as one lumen tube.
Is there a room for the bronchoscopy? Is there a room in this room for bronchoscopy? So I think it should work. It should work.
Yes.
It should work.
Thank you.
There is more questions, please, Dr. Muhammad.
Dr. Saad, are we fine with the time, or?
We're fine with the time. One more question, because we have an important announcement by Prof. Hassan Manna for the next session.
Okay. So one of the question was about the post-operative IV analgesia. What is the drug of choice that you normally use?
In Ohio State, they use, I think codeine is not available in Egypt, so you can give naltrexone, you give intravenous fentanyl. I think there is no big deal here. You will give what you are experienced there.
So they give oral codeine over there? No, not maybe. Not like morphine PCA or something like that, or fentanyl PCA.
Maybe fentanyl.
I think this is
maybe fentanyl till he gets conscious. So then I think there is no more fentanyl except just some policies if he feels some pain.
Okay.
Thank you, Dr. Saad. Thank you, Dr. Saad.
We actually get to conclusion of this session.